Welcome back, Focus Learners, to another Explainer. I'm your host, Harshal, and today we're jumping right into part 4 of our training series. If you've been following along with us, you know we're deep in the trenches of E/M coding. Today we're putting a giant magnifying glass on COPA, the complexity of problem addressed. Because look, without a rock-solid understanding of what makes a condition acute versus chronic, you literally cannot accurately level an encounter. It's just impossible. We absolutely have to get these foundational definitions dialed in before we can even think about mastering the nuances of the MDM table. So, grab your coffee, get ready to take some notes, and let's decode these critical clinical distinctions. Okay, let's dive into this. Here's our quick roadmap for today. First, we'll define chronic conditions. Second, acute conditions. Third, we'll tackle the recurrence distinction. Fourth, we'll look at the condition spectrum. And finally, I'm giving you a really handy chart audit checklist. All right, starting off with Section 1, defining chronic conditions. Let's start by looking at this first major pillar of COPA. When we're reading provider documentation, we can't just guess if something is chronic based on, how it feels. We need hard, objective clinical parameters. So here is the absolute baseline definition you've got to memorize. A chronic condition is broadly defined as a health condition that is expected to last 1 year or more or conclude with the death of the patient. Now that 1 year mark, that is a rigid clinical threshold for us as coders. It's not 6 months, it's not 9 months, it's an expected duration of a full year or more. Period. This duration element is the ultimate gatekeeper for chronic categorization. Let's move to and see how this builds, because beyond just that time threshold of a year, a chronic condition also carries some very specific functional and management traits. The guidelines explicitly state that these conditions require ongoing medical attention, or they limit the patient's activities of daily living. And honestly, it's often both. Just think about the classic textbook examples we see in our daily chart audits. Hypertension, type 2 diabetes, rheumatoid arthritis, hyperlipidemia. These are textbook chronic illnesses for a reason. They don't just magically disappear after a quick 2-week course of antibiotics, right? They require continuous monitoring, regular medication adjustments, and long-term management strategies from the provider. Moving right along to Section 2, defining acute conditions. Now that we've established the long-term, ongoing nature of chronic conditions, let's pivot completely. An acute problem operates under a totally different set of rules. Clinically speaking, an acute condition typically affects just one specific portion of the body. It's got a short duration, a sudden or recent onset of severity, and, this is crucial, it rapidly responds to treatment. It's like a story with a clear beginning, a middle where the treatment happens, and a definitive end where the condition is fully resolved. Now sure, the exact duration might vary a bit depending on the specific disease, but the defining trait across the board is that short, sudden, and highly responsive nature. Which brings us to Section 3, the recurrence distinction. Now what's really interesting about this slide is how it breaks down what is probably the most common trap coders and auditors fall into. There's this massive misconception out there. Listen carefully. Just because a patient gets something over and over again does not magically transform it into a chronic condition. An acute condition can absolutely be recurrent, but it completely lacks that continuous, long-term duration of months or years. Think about it. If a patient gets a UTI, takes their antibiotics, and it completely clears up, only for them to get another, totally distinct UTI 4 months later, that is a recurrent, acute problem. It resolves entirely between episodes. On the flip side, a true chronic condition, something like rheumatoid arthritis, well, that doesn't just vanish between doctor visits. It has an ongoing duration and demands continuous baseline monitoring even on the days the patient actually feels okay. Let's look at Section 4 now, the condition spectrum. So far, we've basically looked at the binary extremes, right? Acute versus chronic. But as we all know, human health is rarely that black and white. There's a whole spectrum in between. Let's talk about how a problem actually escalates up the complexity ladder. Way down at the bottom, we have self-limited or minor problems. These are expected to just resolve on their own with a little time, maybe some rest. But here is the critical escalation trigger you always need to look for in the documentation. If a problem that's normally self-limited is not resolving consistent with a definite prescribed course, it officially crosses the threshold. It graduates, so to speak, into an acute, uncomplicated illness. It has essentially proven it won't go away on its own, and now it absolutely requires active medical intervention and evaluation by a provider. And this brilliantly illustrates what that escalation looks like in a real-world clinic. The guidelines give us these really specific clinical examples of acute, uncomplicated illnesses, things like allergic rhinitis, uncomplicated cystitis, or a simple joint or muscle sprain. Think about a minor ankle twist. Usually that's self-limited. But say the doctor prescribed the RICE protocol: rest, ice, compression, elevation. If a week goes by and the patient is still in significant pain and can't bear weight, let's be real, usually because they completely ignored the rest part of that protocol, well, it hasn't resolved consistently with the prescribed course. Boom. It is now an acute, uncomplicated injury that requires a provider's active management. Finally, Section 5, the chart audit checklist. Okay, we've covered a ton of clinical theory and guideline definitions today. Let's shift gears to practical application. I want to give you an immediate desk-ready tool you can use during your daily chart audits to make your leveling so much easier and way more accurate. Here are your 3 rapid-fire checkpoints. Step 1. When you open a chart, first figure out which specific conditions were actually managed during that visit. Remember the MEET acronym? Was it monitored, evaluated, assessed, or treated? Just listing a diagnosis in the chart doesn't count for beans. Step 2. Once you've got your list of truly managed conditions, categorize the type using the rules we just went over. Is it minor? Is it a short-duration acute issue? Or is it an ongoing 1-year-plus chronic condition? And finally, step 3. Determine the status. If it's chronic, does the provider clearly state it's stable, or is it not at goal and worsening? If it's acute, is it uncomplicated, or are there systemic symptoms making it complicated? I promise you, following these 3 steps will instantly clarify your medical decision-making level every single time. So, the crucial point is this: you just cannot build a sturdy house without a strong foundation. Today, we laid that groundwork by defining exactly what acute and chronic mean in the eyes of medical coding guidelines. Next time, in part 5 of our Explainer series, we're going to take these very definitions and apply them directly to the MDM table. We'll be mastering acute uncomplicated illnesses and acute stable conditions so you can confidently conquer the low complexity category. You seriously won't want to miss it. Because ultimately, without these strict foundational definitions, accurate EMM leveling is completely 100% impossible. You have to know the rules of the game before you can play it efficiently. So, my final question to you is this: now that you have the baseline, are you ready to tackle low complexity? Thank you so much for joining me for this deep dive into COPA. Keep practicing those definitions, apply that 3-step checklist to your charts this week, and as always, this is Decode Healthcare with Harshal signing off.